Good morning, everybody. Yes, Tom ordered me to start, so I'm starting now. Good morning again. My name is Haitham Anosh. I work for the Norwegian Agency for Development Corporation, NORAD. I manage the innovation portfolio for the global health section, and I manage the innovation working group, which is in support for the UNSG's initiative, Every Woman, Every Child. With me here, distinguished panelists who are going to bring their views on the topic, who pays the bill. And this topic makes me feel like home. So we have this discussion sometime at home, who pays the bill. So their views are going to shed light on challenging issue, who's going to provide funding for what and for what reasons. I will leave the presentation or my fellow panelists to present themselves and the work that they are doing. Afterwards, if we have time, I have some points I will go through as donor, how we view funding and how many matters for us. And then at the end, we open the floor for questions and answers. So please, sister, it's your turn.
Good morning. Morning to you all. And greetings from Nairobi, Kenya. I'm here to represent the government, and I'm very happy because in such gathering, we all learn from each other. Each one comes with some experience, and we learn from one another. According to our presentation, it's like we need to talk about who pays the bill. But my presentation will concentrate on how we can work together and sustain any project that we initiate. So can I have the slide on, please? Yeah, as I said, my name is Dr. Ogara, and I work for Ministry of Medical Services, and I'm the head of eHealth. Usually we talk about sustainability, but in a broad sense, we really have to define what is sustainability before we can zero in to the actual. So I have, in fact, and this is actually quoted from the UN agency, which is sustainability is based on a simple principle. And I hope you all agree with me. Everything that we need for our survival and well-being, either directly or indirectly, on our natural environment, sustainability creates and maintains the conditions under humans and nature that can exist in productive harmony and permits fulfilling of social, economic, and other requirements of present and future generation. And I hope you all agree with me. Sustainability is therefore very important to making that we have and will continue to have the water, materials, and resources to protect human health, because we are discussing health here. And even the mHealth projects that we are discussing this to see how we can come up with sustainable mHealth projects. Okay? Resources to protect human health and our environment. And I quote, this is from US Environmental Protection Agency. Now, let's move on and see. In today's discussion, or in the context of our today's discussion, I've defined sustainability as a real sense in the capacity to implement, support, and maintain projects and programs, for example, eHealth project. I'll go straight to opportunities because what I'm presenting here is based on my experience, how we've been working with donors and what has been happening. So there are many opportunities that lie in sustainability projects. And usually when we start projects, we are afraid whether we will be able to sustain project. But there are certain things that we have to do right in order to sustain any project that we initiate. We have opportunities like local commercial empowerment. I don't know how many of us do that when we start our projects. Generation of commercial motivations for entrepreneurs who want to work towards improving health. For instance, in Kenya, we have the banks, we have the telcos, who are outside then ready to work with the government to have sustainable projects. The issue of public-private partnership is also an opportunity. Before, we had a lot of problem in terms of actually working with the private sector. But I can comfortably say in Kenya, this is the way we are going. We have even developed policies for public-private partnership. We interact well, and we have also, we have already established what we call the Public-Private Partnership Health Kenya, PPP Health Kenya, and we discuss a lot of issues there where people can take their share. The other opportunity I will talk about here is leveraging and harnessing corporate social responsibility. And I've mentioned the Standard Chart. For instance, in Kenya, we have Standard Chartered Bank, and they do annual basis, we run. And they collect resources, actually for the blind, to prevent blind. So these are all resources that we can tap in. We need to mobilize the community and involve them. Quite often what happens to us, we initiate projects and the community who are the recipient are not even aware what is going to be, implemented. Then the issue of available resources. They are all opportunities. And availability of resources can be looked into. Either the resources will be there or the resources are not there. Now, what are the challenges? The major challenge we face is that, and if I'm wrong, correct me, there's no donor who wants to fund ongoing projects. For instance, I've started a project and I've reached somewhere in the middle and I'm stuck. Donors wouldn't like that. What they want to do is to fund new solutions. And what does this do? This can actually leave great ideas unfunded, even when project can go to scale. Then we also have projects that sometimes development partners, they bypass the government. And it is true, yeah, maybe we have our bureaucracy that sometimes we slow things. But I'm saying we can all work together. Planned projects must fit in the government overall strategy and action plans. In that situation, we are going to help and actually support what the government is doing and will not waste resources. Now, what needs to be done? All stakeholders must be involved right from the beginning of initiation of any project that we want to implement. The same things applies to involving the government at the right time. Because you see, once you involve them, then they can plan. We need effective governance and leadership. And indeed, coming from Africa, I know that has been our problem. That leadership, and I'm not afraid of saying it, leadership is a major challenge to every position, to every situation, to every project. And I'm saying we need proper leadership. In Kenya now, what we are doing is that the government has taken it upon himself, and now government staff are being trained on leadership, what we call strategic management program, leadership program. And there's a lot we are learning. We are learning how to even analyze stakeholders and how to work with stakeholders and donors. Clear policy, guidelines must be there. In some situation, we don't have guidelines. And then, when, let's say projects are coming in, this is what the government should say, that this is the way we are going to go. We need also legal framework. Standards must be there. Since I came, we started this meeting, I've been hearing about standards and other things. And then the strategy. The strategy actually acts as a blueprint to help us coordinate all activities, all ongoing projects. Government must provide conducive environment to initiate and help implement mHealth projects. One of the important things we need to talk about is the strategic approach to these projects at all healthcare levels. Build sustainability component into all projects. What do we do usually? We usually design, but we don't have sustainable, approach, rather a component for exiting. So then the government is so come, take over, and they are not prepared. We need to identify key action steps, and which are these steps? Establish sustainability drivers and strategies. Engage government early, I've said it and I'll repeat it enough, to prepare for uptake, ownership, and sustainable resource planning. Because we need to factor in somewhere in our budget that this project will continue. So then when even the donor exits, the government takes it on smoothly. We also have to think about the client responsiveness service. It's very critical. And this concerns the community, okay, how we work with them, because even the community has so much to contribute. Strategic management, capacity building, and support. All this can make us sustain projects. Now, what needs to be done continues. We are talking about broad internal communication strategy, even within the government, because we also have our own issues. And for instance, somebody comes in with solution. I've experienced this a lot on my seat. People come, then they tell you, Dr. Gara, meet them. And we meet them, and so what? We have to know where we are going. And the top, policy makers should say, Ogara, you've met them. This is the way we are going. Pick it, move it, create a team, and move with it. And I think if we do that, we will be home and dry. It is extremely important to break the ice between the e-health practitioners and leadership. It is true, because now we are talking about mHealth, we are talking about e-health, and even we as doctors, clinicians, nurses, there's a lot we can do. But are we aware? Yeah? So when we are not aware, there is resistance. So any project that we are going to implement, we need to bring everybody on board. Proper business planning, costing, implementation for long-term sustainability is very crucial here. We often don't do that, and it becomes a problem. Training of critical mass of e-health and mHealth practitioners for uptake of a project is very critical. And I usually know that people come up with solution, but it comes together with a training package. Because now, if you bring me a solution, we don't know about the solution. We have been sensitized. We have to take up this solution. We have to be trained. to be able to take this. And then there must be astute networks and platforms for e-health and mHealth knowledge management. As we talk here, most of our e-health projects are standalone. You agree with me? How are we going to do that? It's through the networking. Through the networking, we should be able to know that, oh, we have CDC who is here. We have, let's say, in Coast, Rockefeller supporting another project. USAID is here. Then we don't step on each other's toes, but we rather add value to what the government is doing. Then we need to, I brought this because in Kenya, according to our new constitution, a lot of things are happening. And we need to actually go to the counties. And in the counties, some are not even aware. So we need to devolve whatever project or system to the counties. In conclusion, what I'm saying is that mHealth project, if well designed and implemented, can assist in achieving the Millennium Development Goals. At the end of the day, this is what we are talking about. The government, private sector, donors, NGOs, and other interested stakeholders must work together. Our roles should be clearly defined, and I know that each one of us has something to contribute to any project that we start. My key message is that there are many opportunities for private sector, even government, NGOs, to participate in building and developing sustainable public health systems. Because at the end of the day, what we are talking about is this mHealth projects that we are implementing, what value is it going to add to future, health systems and health outcomes? I want to take this opportunity actually to acknowledge the Kenya government and line ministries. IFC, they really supported us in terms of pulling out the strategy. CDC Kenya for sponsoring me to be here. CDC Foundation for also supporting and sponsoring. Rockefeller Foundation, DFID, and GSMA. Thank you very much for listening to me.
Thank you, Esther, for bringing the views of the government. Now Stanley is going to bring us views as entrepreneur. Please.
Good morning, ladies and gentlemen. How are you doing today? Okay. I'm very glad that so many people come here because I know this is a very challenging topic. It is still very hard to make money in this section, and today I'm going to share some experiences from our company. And here are two issues I want to address first. DXY, the first is DXY is the largest physician network in China, and we have very large user base, and this is very unique in China because if you have a large user base, it's much easier, much faster for you to disseminate, to promote your mobile applications. So this is one thing. The other thing is, since I'm from China, and today all the stories I'm going to talk about happen in China. And there are a lot of differences between China and the US, regulations, policies, social structures, health care systems. You have Obamacare, and we have Who Care. So, but today I'm not going to talk about the differences too much because today I'm going to talk about something in common so we can share the experiences from the presentation. The topic is looks like a frustrating opportunity in small business, but everything grows from small. So the key point is how can small business grow big? The first slide shows some basic data of DXY. DXY is a very well-known Chinese doctors community, and we have about 3 million users, and 60% of them are licensed physicians. Yesterday, some people talk about this is very hard to collect healthcare providers online. I know this is very true because we have put a lot of effort to collect these doctors to make them very engaged online. And we have 23 million posts. We have also used the collect intellectual to publish. We have already published about 70 books in Chinese, and we also published 16 open access journals, academic journals. They're all in English, and 4 of them have been indexed by PubMed. And we started to develop our own mobile application since last year, and we have developed the first 2 application is about drug information. The first one is for the professional people, for doctors. The second one is for the lay people, ordinary people. So these 2 applications are data-driven. I mean, the drug information, drug-drug interactions, side effects, something like this. And the second one is IDXY. It's also called the DXK. It's a sociality because DXY is a social network for doctors. So we developed this app, so doctors can install this app in their mobile phone and use this app to interact with their colleagues or peers. And the last 2 are content-driven mobile applications. The Orthopedist Times and the Oncologist Times. It's kind of news terminal on their smartphones, so the doctors can see the latest progress, the most well-known information from the websites. So we develop these 3 types of mobile applications. And how much money have we got? In the past 9 months, we collect 1 million RMB. It's about 160,000 US dollars. It's not big money. But in next year, our expectation is to collect 1 million US dollars from our mobile business. How can we do that? I will explain this to you. First, I want to show you the big opportunity in China. We have the largest population in the world, and the internet user has been reached about 500 million something. A high incidence of chronic disease, a rapid growth of smartphone users. Here I showed over 100 million, but the latest report released by KPCB on yesterday said in China the smartphone owners are over 270 million users. So that's a big number. A rapid growth of healthcare market. China is going to be the second largest healthcare market for pharmaceutical industry in next year or 2014. And also the increased level of education and living conditions for Chinese people. And also I have mentioned healthcare system cannot meet the needs from the public. I know the government is is still working on this. This is a very difficult part. And right now our policy is universal coverage and low payment. This is a big opportunity, but the reason why I said this is a small business is because these 2 reasons. The first one is users are still have a lack of payment habits. People prefer the free services, free content. Everything is free online, so it's very hard to collect money from the users. The second one is quite interesting. I have to say the data is still dead in China. The data is still sleeping in the government, in the hospitals. It's not very well utilized. So big data is still a dream. There is a still to go in China. The data interface is not open, and the data does not meet the standard, the criteria. So the second part, it is very hard to change, and DXY cannot change it either. The first one, I think it is possible because there is still something user would like to pay. So our business model is user-driven business model. So our strategy first to find the demanding points and filter out the most valuable points from all kinds of demanding requests. I will discuss this in my following discussions. Forget about big data, because right now in China, I have explained that it is very hard to collect data. And I think it is also a good idea to start from small data, like drug data, drug information. We collect drug information from the package insert in the medicine box, and we encourage doctors to mail these information to us, and we use scanner to scan these information and transform this into the text. Many people talk about innovations, especially the guy from the consulting firm. But I have to say that small improvements can also make big difference. So the innovation is also from the small improvements, especially when you are developing your own products. You have to collect the feedbacks from users very quickly and select their valuable parts and change your products and release them as quick as you can. And health app has great users, but medical app has great cache. Medical app is much closer to the cache than the health app. And sometimes just to forget being M. The reason why I say this because I noticed there is a trend that when we talk about mHealth, everybody just want to copy everything from PC to the app. And several days ago, I just saw an application that trying to copy everything from the working station in the hospital. I really hope I could use a knife to sharpen my finger to the application, because there are so many information on the iPad. Here is my personal suggestion, just to forget being sometimes. Here I want to show you some of our products. The drug assistant, this is our mobile applications. We also collect some Chinese traditional medicine and also some information and medical calculations. IDXY, also called DXK, is a sociality application. So doctors can use this app to interact with their colleagues or peers, discuss about some cases, and also find their colleagues. Oncologisttime is a content-driven product. So we provide some information, some news through the mobile applications, and also some CME content. And also previous, the time is quite similar with the oncologist-time. So which app is the killer? The data showed here is very interesting, that the first two are data-driven. The third one, Xpays, IDXY, is the sociality. The last one is the content-driven app. So if you see the percentage of using in last week and average using time, you can draw a conclusion. It's right here, that content is king. Content is the killer. And the second one is sociality. The last one is data. It makes sense because doctors spend a lot of time on reading their own specialties information. But if they check drugs, maybe they just it may just cost them maybe 2 minutes, because doctors are quite similar with the drugs that they always used. But I have to tell you that all the money we collect are from the data-driven app, not from the content, not from sociality. Is this possible to collect money from content and sociality? I think it is possible. So let's go back to our strategy. The first one, figure out the demanding points. I think doctors are still quite interested in the content. So let's think about medical researchers. They have to pay money to buy the full text. Let's think about medical students. They have to pass the examinations. They have to read the textbooks. So there are still a lot of opportunities in content. But sociality, I think probably sociality is a kind of indirect way to make money. Like you can recruit many doctors, like an online focus group, and help pharmaceutical companies to launch a marketing research and provide some opinions from doctors, help pharmaceuticals to make a marketing decision. So this could be a very indirect way to make money in terms of sociality app. And here is the device analysis. Android is still ruling the market in China. iPhone and iPad are the second one, and Windows Phone are the last. I know you probably heard a lot of reasons to explain why Android is ruling the market, but I think in China there's another special reason is because I think Chinese people prefer Android even 5,000 years ago. Check it out. This is a container proved to be a 5,000 years ago founded in China. It's lovely, isn't it? Here are some rules always on my mind. I didn't list here. Rule number 1, be patient. Be patient about making money. Making money is very difficult. It's not easy. You still need a long way to go. And rule number 2, be quick. Be quick on the product development. So it's not contradict with the rule number 1. Be patient on the money and be quick on the product. And rule number 3, be honest. Here I want to show you one figure. We call it week the number 1. In China, some companies, it is not very rare in China. Some companies use some people under the ground to buy the app on the weekend because the rank in App Store will not change on Saturday and Sunday. So some companies just buy their rank on Friday night. This is the Friday night, October 19 at 8 p.m. You can see a dramatic change of the downloading. So if somebody come to you to tell you that we are number 1 app in China, you can just say, oh, really? Interesting. And think about it. Thank you very much.
I need to just have my iPhone AirPlay, so I can just kind of hit AirPlay and it'll come up. Nope. Nope. Other one. The first one you had up when we started. There we go. Thanks. All right. I'm going to share with you U.S.-oriented business models and approaches to making money and give you a framework for thinking about it. When we've looked at different levels of success, what we found is that the ability to get adoption of a business model is directly related to the amount of change in the practice of medicine. Anything that requires a lot of change in the practice of medicine will be very slowly and cautiously adopted. And then when you look at who's also paying for it, so you look at the wallet that's being approached, anything that can actually increase the wallet of the physician with almost no change will get adopted very quickly. Anything that requires the payer to open their wallet to radically change the practice of medicine will be very slowly adopted. And so you can kind of walk up this stair step of these 6 different business models and see if you want to get early, quick traction, the type of business model you have to have, which is a very limited amount of change or no change at all in the practice of medicine, and trying to basically make doctors or enable doctors to make more money. So let me give you some examples. So model 1 I call feeding the beast more of the same. So what we're doing here is we're just enabling medical practices, ZocDoc's the example, of just making more money without changing the way that they practice medicine at all. And for this, doctors will pay $250 a month for the privilege of putting their schedule in ZocDoc so you can find them and schedule an appointment online with your phone immediately. Okay? And this company's become very successful, raised more money than probably almost any other mHealth company from the venture community, and speculating that it might go public this next year. Now, what's interesting here is that once ZocDoc has gotten some traction in this minimal change business model, now they're actually moving up one step to the next level in this progression. So here we call this feeding the beast more efficiently. So what they're doing now is they're taking the clipboard that you have to fill out every time you go to the doctor, no matter how many times you've seen the same doctor. They make you fill out the same piece of paper again and again, it seems. And what they've done is they've automated that process. So you can actually do that at home on your app or in the waiting room or whenever, and now that's electronically loaded. So now it's now made the administrative processes of the practice more efficient. Now, obviously, that's great for you as a patient. It saves you time, money, and hassle as well. But it also then adds more value to the practice to make their application stickier. Model 3 is what I call changing the way the beast eats. And here what we're talking about is actually providing new types of services. This is iTriage as an example, where they've now integrated in different insurance plans. They've integrated in your personal health record. And through that now you can actually find different types of service providers, whether the emergency rooms or physicians or urgent care centers or whatnot. And so now they're actually integrating more and more of the administrative activity so that the process is more efficient. They've also been one of the top, you heard yesterday from the Aetna folks who acquired them, but been one of the top downloaded apps. They've got a revenue model that's very successful as well, getting providers to pay for their services. Then what we do is we move this forward again. Model number 4 is feeding the beast new things. And so what we have here now is doctors providing new services, not the traditional services, but providing new services through a mobile environment, interface, and utility. And so here you've got Teladoc as an example. iTriage has moved in this direction as well, where now you can get nurse-related services so that if you want to just have a nurse call center, you can access that. And so now we're able to deliver a different type of clinical or administrative service through this sort of medium. Then we've got the way of delivering new things with the same wallet. So here's an example of where you can actually go. You know, some people don't want everyone to know that they've had STD problems. Shocking, I know. The doctor earlier today talked a lot about those things. And so you may actually not want to have your insurance company pay for something they would pay for. And so you can actually get these sort of tests and then decide later on, after you know whether or not it's positive or negative, whether or not you want to have insurance pay for it. And so here you can actually change the wallet that ends up paying for it, where you can have traditional payers or yourself pay for it. And finally, and this is where I think we oftentimes get stuck when we talk about mHealth and reimbursement, because when we've surveyed thousands of doctors across the United States and 9 other countries. And we've asked them, what do you think some of the biggest barriers to the adoption of mHealth are? In the United States, the #1 issue is reimbursement. Doctors say, well, I'd love to do it if they just pay me to do it. Well, actually, there are lots of other ways, as you've seen, to make money in mHealth. For doctors, oftentimes they think, well, if I'm going to provide the current type of service that I do in an mHealth format, I need to be paid for it. There's got to be reimbursement for it. That will eventually come, but actually that's the last business model that will be successful. So we can't have that as the gating item to actually get mHealth adoption. We need to look at these other 5 business models first. And the other interesting thing we've seen is when we've surveyed doctors and we've surveyed payers on paying for mHealth, what we find is that, ironically, insurance companies are more willing to pay for mHealth than doctors are willing to provide it. And this gets to this issue of the change in the practice of medicine and how disruptive it is. And so even where insurance companies are willing to pay for it, doctors are still generally fairly reluctant to actually deliver health care in a new modality, which is the mobile health modality. So when you think about this now, we've talked about these 6 different business models, and now when we start to think about it in revenue model terms and overlay that, you see a similar sort of progression where you've got different business models, such as a freemium model, an advertising model, which is Google's model. You've got upsell of content, basic and premium apps. You've got devices with apps. About 25% of all the mHealth apps out there have a device component. And those that actually have had some of the best revenue success are ones that sell a device with the free app or sell a device with an app that has a premium version. So it's the combination of those things. And then mobilizing existing services, again, is kind of the last. So as you think about business models, this is kind of my last slide. Think about these 6 different business models and revenue models, and which revenue models you need to combine with which business models in order to really create the best type of success for commercial opportunities and making money matter within your business.
Good morning, everybody. So I'm Eric Woods. I'm the CEO and founder of Switchword. And when we first started looking at the global health space, specifically in Africa, we really tried to look through the lens of an actual health worker, so what their day-to-day reality was. So with only 2 years of clinical training after high school, and most health workers practice in isolated rural clinics, serving a patient population of anywhere between 5,000 and 150,000 people. They're performing complex procedures with only basic equipment, diagnosing complex cases, and managing outbreaks, disease outbreaks, when alerts or lab results take 2 months to reach them. What we did find is that each of these health workers actually had a mobile phone in their pocket. So they had the potential and the tool to be able to reach colleagues nationwide or reach the Ministry of Health for support. They just didn't know who to reach out to. So we started asking some really basic questions. What could you do if you actually collected the mobile phone number of every health worker, and how would you actually go about doing that? So we first started in Ghana and Liberia. We started by partnering with mobile network operators. We partnered with Vodafone in Ghana and MTN in Liberia, and connected all 2,200 doctors in Ghana and all 181 doctors in Liberia. And that's 181 doctors serving more than 4 million people. And we connected them on a free calling network. So it allowed any of those practitioners to reach out to others and call completely free of charge, whether they were seeking advice or referring patients. So since we started, we've had more than 4 million calls between practitioners. So people were working together nationwide to improve patient care. But what really excited us is that we're actually generating millions in revenues for our telecom partners. In Ghana, Vodafone had only 18% market share. But after we launched this project, they had 100% of the physicians. So as those physicians made paid calls to other friends and family who were not practitioners, that was generating millions in revenue for our telecom partners. So we had generated 1.5 million in revenue for Vodafone in Ghana, and that's on a network of just 2,200 physicians. So that's really the key for us in terms of scale. So it was all about incentivizing health workers to actually join the network, but then providing that revenue potential for our telecom partners so that they actually had a reason to provide that incentive. So using this revenue as that carrot, we're now building the largest network of health workers in the developing world. In Tanzania, in close partnership with the Ministry of Health and Vodacom, we're going to be building a network of 9,000 practitioners. So we're going to connect 6,500 rural medical and clinical officers. So these are the people that are serving on the front lines at health centers and dispensaries at the village level, and connecting them to more than 2,500 urban doctors and specialists. So this network of 9,000 practitioners will form the largest network of health workers in the developing world, with nearly every facility in the country connected. So how we do that is we have a USSD registration system. So this is a system that works on any type of phone. And we collect key information like name, specialty, location of practice. And then working with the ministry, we actually verify them as legitimate practitioners and then get them onto a database at the Ministry of Health. So that database and that directory of health workers provides the critical backbone for rolling out other nationwide mHealth services at scale. So with that directory as a backbone, there's 3 really interesting things you can do. First, you can connect people. So in Tanzania, we'll be launching in January, so next month. And then we'll follow up with a health worker directory. So it basically allows any health worker to seek support to anyone else in the network. Because they're part of this free calling network, they can call and talk as long as they want, completely free of charge. So we think that allowing people to find knowledge locally and at the colleague level in terms of other experts in their field is really critical in terms of providing support to people in real time. Next, if you have a database of every practitioner in the country, we think you can actually communicate with them in real time. So using something like a bulk messaging platform. So we're building our mHealth services on top of Vumi, which is an open source platform developed by the Preikelt Foundation. You can blast a message to every person in the country, or you could target messages to specific regions, districts, or individuals. So if you wanted to send best practices, disease outbreak alerts, or lab results, if you actually know who's in the field, where they are, and their phone number, then you can target message to them directly. There was a randomized control trial in Kenya that showed that just 2 text messages a day to health workers, and this is the same types of health workers we're targeting in these rural health centers and dispensaries. Just those 2 text messages a day with basic pediatric malaria care protocols improved patient care by nearly 25%. So simple interventions at scale can have profound impact. The last piece, if you have a directory of every health worker in the country, is you can actually collect data from them. So you can have people reporting disease outbreaks. The Ministry of Health could send out a monitoring and evaluation question by SMS, blast everybody in the country, and instantly get responses back into the system. So we think the key is really incentivizing health workers in terms of giving them a monetary reason to register for a program and then maintain their phone number in the system, and then proving to telecoms why they should be supporting these projects so that there's a real revenue potential for them, because that's what they care about. So at Switchword, we know that one health worker can impact thousands of patients, but a network can change the lives of millions. Thanks.
Thank you, Eric, and the rest of the panel. Before we open for Q&A, there are some points from our point of view as donor we would like to go through. Just starting with the talk show I watched for some years ago when a multi-billionaire was asked for the reason for him to make, that made him make all the money, and the answer was because I had none. It was too simple. So for us, think if the notion of this example is we human beings value what we don't have most. So think of all the children and women that do not have access to health services, how much they value those services. And this is our starting point. When we do invest in mHealth and in MNCH, so we would like to accelerate achievement of MDGs 4 and 5, the health MDGs. So this is our starting point. This is our interest. We think more commercial maybe in summit like this, but as donors, so accelerating health MDGs is our primary interest. So money does matter, and that's why we are happy to play the catalytic role. Yesterday I heard a colleague who said, I don't like this expression. I would like support, but I keep catalytic because it is catalytic. And in that lies also our interest of being catalytic, and somebody should take over after we prove what works and what does not work. And by saying so, I'm thinking of the governments. So Esther mentioned many issues that governments should take care of, and I agree with her. So governments, national authorities should be part of enabling the environment. Because if, as you said, we are asked to fund something that is ongoing, the answer you will get is, how did you do your budget? So you plan for something that you don't have coverage for, and so on. So you will get this answer if you are not, if you don't do your homework. Money does matter as well when it comes to being counterproductive. And by saying so, I mean we donors, we should put our act together to avoid fragmentation. Fragmentation is pointed at as the main obstacle for scaling up mHealth projects. And it will be just ridiculous if donors contribute to more fragmentation by not putting their acts together. So we are happy, and we do so coordinate our act as donors. We have a joint venture now, which is going to be exciting for us in the coming years in Nigeria, through supporting the initiative of the country to save 1 million lives. The last point is we do also in NURAD coordinate innovation working group. We do follow up different work streams. The overarching principles of what we do in the IWG is private-public partnership, sustainable business models, and innovative financing. And in that, we develop a report that landscaped innovative financing models, identifying 6 structures that can be vehicle to attract private capital to support everyone every child activities. We brought JP Morgan to consider those models and give us recommendation of what we can go further with. And after we did so, we went back to the network of IWG, asking people, okay, do you have projects that can fit into some of those models? And what kind of needs do you have that can be used to develop new models or structures to attract private money? And guess what? No answer came back to me. So we should not blame only donors. We should think also, reflect on that. Why? Is it too complicated that people are not interested in investing time to explore? Or are we just used to the traditional way of raising funds? Okay, I give you an application, you give me money, and I report back to you. That's it. Because we see the philanthropic wave is very high, interest from big money to invest, to support. So we should proactively explore those opportunities. So by saying that, I would like to open the floor for questions and answers.
Hi, my name's Anup Selgi. I'm from Cleveland, Ohio. I'm an emergency physician, entrepreneur. I have a startup down in the startup kiosk downstairs. But I have a question, actually, for the gentleman from Switchword. What you're doing is incredible. And I wanted to ask you 2 questions. One, how did you get the funding to start this company? Was it from government grants or so forth? And the second one is specifically when it came to malaria, those 2 text messages, which impacted malaria. What was the content of those messages? What specifically, created or caused that change? I mean, 25% is incredible. The reduction in malaria with those 2 text messages. What was it specifically that caused that? Thank you.
Yeah, thanks for your question. So Switchword is a 501c3 nonprofit organization, so I think we like to think like a social enterprise. So we're funded by Google.org, Mulago Foundation. But I think we're definitely thinking about whatever project we implement, what's the business model behind it, what are the incentives for any partners. So again, we work really closely with the Ministry of Health, so making sure that they're closely involved with the project, but then in terms of involving carriers, it's all about proving out on an individual customer basis how much revenue we can generate for them. So one thing that's going to come out in Tanzania is we'll actually have records of every single call that's going on within the network. So we'll be able to understand how this huge network of people is actually working together, but we'll actually have transaction data for each person as well. So we'll know how much a rural clinical officer is worth, how much an urban doctor is worth. So really we're proving out the revenue to our telecom partners. So the goal for us is to eventually get a revenue share either on that closed user group model or mHealth services. In terms of the malaria research, so that was a study I can share with you. I can't remember the researcher offhand, in Kenya, and it was just basic best practices in terms of malaria management, and I think they would tag a message on the end with some encouraging words. So I mean, I can refer you to that research. This isn't something that we performed. This was a researcher in Kenya, an RCT, but that's the type of project we think that's really easy to scale when you actually have this network of people already in place.
I have a question for you, Eric, as well. So I'll take the objection to that. Did the telcos believe that you could actually generate revenue for them? I mean, how difficult of a sell was that?
So I think when we initially started, I think it was just kind of, oh, this is an interesting project, let's see what happens. And it was specifically, we started with physicians who are really high value customers for them. So from there, kind of the fortuitous nature of the network starting, we then from there had these usage statistics that we could use to prove out the value of these networks. I think that was the really critical piece, is now we're making sure that we're collecting all the necessary data so we can prove out exactly how much these networks are worth.
They did it more out of an interest and maybe charitably to be nice, but not from a commercial perspective, and then they were surprised by the commercial benefit.
I think they saw opportunity on both sides, but they were really thrilled with, yes, how much revenue was generated.
Okay, thank you. We take one.
Thank you very much for the interesting talk. My name is Young Jijo at Johns Hopkins Bloomberg School of Public Health. I have a question to Dr. Ogara about your interesting comment about that donor do not like to funding to ongoing project and seeking for new solutions. Because one of the challenge for many NGOs right now is there are many NGOs who demonstrate successful pilots, but they want to really scale up for the next stage, and they are looking for other fundings. So in that regard, I think we need some different strategies, communication strategies, approaches to provide funding for scale-up stage. So in that regard, I wonder whether you could advise some like appropriate approach or strategies. Thanks.
I basically mentioned that in my strategy, in my presentation, and I mentioned the way even we communicate. You might find out that, you know, there are resources somewhere that one can tap in, but because we don't know what the right hand is doing with the left hand, then we keep on, you know, duplicating, and we feel that, you know, resources are not there. But you remember I also mentioned that even from the government side, we also have our own problems. And we need to work on all these, you know, problems which can actually create conducive environment that we can, you know, scale up some of these, you know, best practices.
Okay, please.
Yes, my name is Mark Wine. About 30 years of my career was in the VA central office here in Washington, and now I'm a director for Health IT, Federal Health IT, with Price Waterhouse. Freeing the data from the personalized application level is very important. You pointed out, and certainly for the future in the United States, there will be, there is now the beginning of the federal HHS initiative to identify the technical features for the future health learning system that would be open collaboration, open architecture, operating environment with ecologies of applications to personalized health in use, data use, operating within it. What is your outlook for a global health learning system that would take my personal health indicators that I put up and eventually trend and provide knowledge, harvest knowledge to the point of care globally, because we're now a global world from China to US and places beyond?
Thank you very much. I think the basis between all kinds of mobile application is scientific evidence. Scientific evidence is very important, very crucial to all mobile apps, especially the apps who can help you to make clinical decisions, something. So I personally, the knowledge should be shared by all mankind, and it is very important for US to open the data interface to let the developing countries to access the knowledge under some kind of copyright protections. So I think the basis is the evidence-based medicine. But there is still a debate about evidence-based medicine right now. Some people say that evidence-based medicine has become evidence-biased medicine because some of evidence are quite conflicting with each other. They're all from the very reputable hospitals, institutions, researchers, but this is the issue inside medicine. It's not about the model. I mean, the model is still should be evidence-based medicine. So this is my personal perspective. Thank you.
Okay, thank you. We take one.
Thank you. I'm Mira Shaker from the World Bank, and I just actually have more of a comment than a question. Because this issue has come up in several sessions that I've attended yesterday and today, this refrain from, particularly coming from the governments, but also coming from some of the private sector groups, that donors are pushing for fragmentation and that the donors are not interested in scale up, they're only interested in innovation. And I just want to say on behalf of the World Bank that our comparative advantage is not really innovation. Don't say that. Don't tell anyone I said that. Our comparative advantage is really taking the innovation that others may have done on a pilot scale and taking it to scale. Scale is our reason for existence. So if you have pilots, we at the bank are certainly very, very interested in helping to scale them up, but we will have a session this afternoon to talk about what kinds of pilots can be scaled up. Many, many pilots are designed never to be scalable, and that is a problem, and that we often come up against. But hopefully we'll talk a little bit more in the mHealth value chain about this issue. But if you're looking for a one-stop shop for scaling up, it's the World Bank. Thank you.
Let me just add something to that, because the pilot problem, we call it pilotitis, it's a disease, is not just a problem in emerging countries with donor NGO funding. We have pilotitis throughout the United States, throughout Europe, and all these developed countries. And when you try to understand why we're suffering from pilotitis, it actually comes down to a couple of things. One is you ask yourself, who was asking for the money, and why were they asking for the money? And it's almost never doctors asking for the money. It's the marketing department, it's the IT department, it's people that want to experiment and try things, and they think that they can, create greater, and I'm not talking about Africa, I'm talking about the United States, right? And so what happens is after the pilot has been done, and almost all the mHealth pilots that you'll see will show success, okay? So you ask, well, why aren't they scaled up? It's because the doctors and the healthcare practice was never involved except as just part-time labor on the pilot, and the overall practice doesn't believe in it, and they won't fund it. And so, and the reason they won't fund it is because these pilots that we're doing, they were never actually developed in a way that it creates good practice of medicine in a new form. So doctors don't want to change the way they practice medicine, fundamentally is the problem. And when we talk about changing workflow of doctors, there's got to be a compelling economic reason for them to do so. And most of these pilots don't actually address that. So when the stuff came out of the UK recently about the whole demonstrator project, there's a lot of criticism that although it showed great clinical outcomes, it didn't save any money. Well, why didn't it save any money? Because the UK healthcare system is viewed as a fixed cost. So if you actually have the hospitals empty because you've got such good mHealth solutions, they're still going to pay for doctors and hospitals. So we've got to come up with ways that actually both create economic value and clinical value, and that people win from these different solutions.
Okay, please.
Well, I was also going to talk about palliatitis, and I think Chris has actually tackled it very well. But I want to thank World Bank for, coming out to tell us that they are basically ready to scale up some of these pilot projects. Thank you.
So I'm going to apologize in advance if this doesn't sound like a question, but I'm going to suggest that it should raise in all of your minds a huge range of questions we should all be asking. So one of the questions we should all be asking is, are we working with the most innovative social enterprise in this sector helping us solve this problem? And I would suggest Switchword is an example of that kind of enterprise. And if you look at most public-private partnerships, not only do you not have the most innovative social enterprise involved, you don't have any social enterprises involved. So you certainly don't have the most innovative one if you have none. So that concept that although many of the things you'll be trying to do in the public-private partnership will not be fully sustainable, but you still need to pose the question, where can I find the most innovative organization that is sustainable for part of this problem, that can bring something sustainable to the table that I can build on top of? I think it's fascinating to imagine what would happen if you could somehow connect Switchword with M-Pesa and tie it back to Save the Children and Child Funds database. So now you have the ability for a community health worker to be paid for an activity while she's talking with other community health workers directly to the donor who would say, I want to fund that activity. So there's kind of two social enterprises. And then one other question I would suggest we need to be asking is, are we not scaling things because we're spending too much money studying them? We're massively overinvested in studying. We're massively underinvested in scaling. It's the same money. It's not two independent pots of money. So I'd be very interested in your comments about that trade-off between scale and study, and about the idea of looking for the most innovative, sustainable organization to be part of the partnership.
Just before you comment, we take one question, and then you comment both.
Hi, this question is for Eric and maybe Chris. Suresh Srinivasan, emergency physician, CMIO Children's Hospital, Detroit. Your numbers were amazing, and I've also read that the medication compliance amongst HIV patients in Africa also jumped a lot based on text messages on flip phones. It's a win-win situation. The patient care improved, the networks made money. My question is, as a 501c3, can any part of that be replicated here? And I realize the regulations and compliance is different, but to look at the childhood obesity epidemic, etc. So, and it's sort of a different take on the same question from the previous questioner. Do you have in your thoughts that something could be done here based on your experience in Africa? Thanks.
Sure, thanks. So I think, the core of what we do is think about if we want to get to scale, so nationwide scale in any of these countries, looking at the constraints within those countries and then basing your intervention on what you can do at scale. So I think specifically within African countries, we're trying to use basic mobile phones, so things that are based on text and voice. I think when you come to the US, you have things like smartphones. So I think the work that Stanley's doing is a really good example of this, that there's a technology piece to all this, but it's really about networking people and growing those networks so that then those become the conduits for you to be able to share information, send information, collect data. So I think we've built our interventions specifically for perhaps lower income countries that are based on the more basic technologies. So I think specifically in the US, I think the same mentality applies, but I would probably focus more on smartphones and internet-based interventions. But I think through all of this, a big theme through this conference is scale, so that I think a lot of past conferences we've seen a lot of evidence come out for these small-scale pilots, but everybody needs to be thinking about what is it going to take, how do we modify those pilots so that they're designed to scale.
And there's a lot of text-based programs going on that are supported by pharmaceutical companies, different sort of providers, a lot of things that show that you can decrease or you improve smoking cessation, you can decrease obesity levels through texting. There's an organization called Atlantis Healthcare that actually has got some very sophisticated behavioral psychology that they apply to texting, because what you find is that all texts are not created equal. And so this type of text, the frequency of text, the message within the text, the tone of the text, all those things actually impact the efficacy of the text. So there's a whole science around texting that is actually emerging right now as we speak, and it applies in every market of the world.
On this point?
On your point, so here's the problem that we've had as we work with clients that are stuck in pilotitis versus scaling. And that is that, and I'll give you a quote from Adam Darkins from the VA. Okay? When he first started doing remote patient monitoring, and he told the world that he was going to lead this drive towards remote patient monitoring, everyone told him, it'll never happen. The VA is this mishmash of lots of different practices. You can't control it. It's this multi-headed hydra. Forget about it. You're going to be a failure. Well, he actually succeeded. And then when he succeeded, everyone said, well, it could only happen to the VA because you actually have a capitated system, and you can actually control a lot of the variables, and you can't do it another. And the reality is that after the VA did it, they published the results, and it shows that you decrease hospitalization by 25%, you increase patient satisfaction to 90%, you decrease mortality by 50%, all these great statistics that if you actually could bottle that up and put it in a pill, it would actually be the best blockbuster pill ever made. But yet you still can't get doctors to do it because they want to do a pilot in their clinic because they're not the VA. And the VA is special, and the VA is different. And so you find every doctor, every hospital, every practice thinks that they're just enough different that they have to test it in their place first. They just can't take it on faith that because it worked in one place that it actually can be scaled up in another, so they have to do their own test, their own pilot.
But that's the study addiction.
That's the study addiction.
It's supported by the whole ecosystem supports that study addiction.
But it's not just for this. I had my own medical device company, and I would go to Chicago to sell my medical device. And they would say, well, any other doctors in Chicago use it? No, we have doctors in Texas. Well, we're different in Chicago, so we got to do, you give us your device for a month for free, and we'll try it out and see if it works. So this is actually rife within healthcare. It's not unique to health, or it is rather unique to healthcare, but it's rife within it, and it's not unique just to mobile health.
We take one more to be the last one.
Yeah, hi, and maybe we can have a follow-up as well, but it's a question about Switchword, really. I'm Ed from Instead, and we've had experience working with mobile operators and community health workers at scale. And I'm wondering if the strategy of having the free calling service in between community health workers within a network operator doesn't really generate new revenue. Rather, it's more like a promotion or a donation that brings in people from one competitive operator to another. And it might look like new revenue to the operator that is winning the market, so to speak, because they're earning those minutes and SMSs to other people that otherwise the other one would have. But I don't know if you can actually characterize it truthfully as new revenue. And also I'm wondering what's the effect, considering that network operator coverage in a country is not uniform, and whether those who are actually left in the low coverage areas of that phone company are left out even more as pariahs, as people actually have to pay to call them. So maybe we can sit down later and actually understand what the revenue is, where is it really coming from. But maybe you have a comment. I think it's a great platform, though, for the future to have those users and the network agreements to build business models that actually generate new monies to pay for the expenses later on.
Yeah, so I think
but maybe you can explain that a bit better.
Yeah, we're definitely very deliberate about how we negotiate with telecoms. So we involve the Ministry of Health from the beginning, negotiate with multiple operators, looking at the market shares, things like coverage as best as we can. So we try to take that into account with the process. So we don't just go with the best offer, it's hopefully the best coverage as well. I think part of the way we started, like I said, was with physicians. So we figured out what these high-value customers were really worth. So when we negotiated in Tanzania, we said, you'll get these high-value customers, but we also want you to connect the frontline clinical officers and assistant medical officers who are perhaps of lower value, but still people that own phones and are revenue generating. I think by packaging kind of the group together, you can get further and further down the health system. So we aspire to connect community health workers. There's some issues in terms of if they have phones in the first place, how you go about verifying them as legitimate practitioners. But I think it's possible. And I think the way that you convince telecoms is through those usage stats. So if you can show the statistics, it reduces their risk in terms of taking on these new groups.
And if you're looking for a new plan until I can talk you afterwards about
Yeah, great.
Okay, thank you for